My name's Dan Lomas. I'm one of the surgery residents here at Langford, and this is the final part in this webinar series looking at how to manage a dog with a mechanical intestinal obstruction. I'm going to talk you through performing an enterotomy to remove a small intestinal foreign body. We're going to look at preparing the patient for surgery, the equipment you'll require, the surgical technique, and then some of the potential complications that you could be faced with. So when preparing your patient for an abdominal surgery, you want a wide clip, ideally going cranial to the xiphoid and caudal to the pubis, as you can see in this photo, and then 4/4 drapes and draping wide so that if you need to extend your incision, you'll have plenty of space. For the equipment you require for this surgery, a general surgical kit, including a variety of scissors, thumb forceps, traumatic and atraumatic, and needle holders. Abdominal retractors can assist with visualization. Laparotomy swabs are required for minimizing contamination of the abdomen, and radio-opaque swabs are really useful for checking if your swab count is off. Doyen bowel clamps are useful for occluding the bowel when you perform your enterotomy, but if you don't have access to these, an assistant can be used to occlude the bowel. A selection of suture material will be required, and then optionally you can have access to electrosurgery for managing hemostasis. So, before you approach the abdomen, perform an instrument and swab count. You can open the abdomen all the way from the xiphoid process to the pubis, and in this case we're approaching the abdomen in a male dog. So when performing an exploratory laparotomy in a male dog, you extend the incision laterally to the prepuce when you're performing the caudal part of the incision, and this is performed lateral to the prepuce but medial to the nipple line. Once you're within the abdominal cavity, the falciform fat can be excised, and that will aid with your visualization of the gastrointestinal tract. The first step of your exploratory laparotomy is to explore the whole abdomen. Palpate the entire GI tract. So start at the gastroesophageal sphincter, which can be palpated under the rib cage. Follow the stomach into the descending duodenum, all the way down to the caudal duodenal flexure. And to access that, you may have to exteriorize the jejunum. Following through the entire jejunum, ileum, ileocecal junction, and then ascending transverse and descending colon to the level of the pelvic inlet, palpating for firm foreign bodies. Once you have identified your foreign body, exteriorize it from the abdomen and isolate with damp laparotomy swabs. The more swabs you can place at this stage, the better. So if you have any leakage from your section of bowel, that's contained within the swabs and doesn't result in contamination of the whole abdomen. For foreign bodies that are located at the caudal duodenal flexure, transecting the duodenocolic ligament can assist with exteriorizing as much as you can and allow you to visualize that segment. Place Doyen bowel clamps, proximal and distal to your obstruction, to minimize any leakage of intestinal contents. You can also use your fingers to milk abdominal intestinal contents away from the section of bowel you plan to occlude. And at this stage, I'll prepare a selection of instruments that will be considered your dirty instruments. That leaves a selection of clean instruments for closing the abdomen. Once you've done this, you then assess your section of bowel for viability. And the question you're asking yourself is an enterotomy suitable, or do you need to perform an enterectomy? The colour, the texture, and the presence or absence of serosal bleeding are the key factors you'll use to determine this. So in this case, we've decided to perform an enterotomy because we've deemed the intestinal viability acceptable. Here you can see we've isolated our small intestinal foreign body using laparotomy swabs, and using a sharp number 11 or 15 blade, we're going to make an incision on the anti-mesenteric border of the small intestine, distal to the obstruction, and ideally within a healthy section of bowel. So you can see here I'm incising into the normal looking section of bowel. Once you've made your initial incision, you can extend that using Metzenbaum scissors, and ideally we're wanting this to be a length that allows us to remove the foreign body without any tearing at the ends of our incision. And you then gently milk the foreign body out of the incision. Alternatively, for foreign bodies that won't come out as easily, Alice tissue forceps can be used to grip the abnormal material and remove it via your incision. The next step in this surgery is to close your enterotomy. In the photo on the screen now, you can see I'm trimming the mucosa from the edge of the incision. Everted mucosa occurs quite commonly when you incise into the small intestine and can make achieving accurate apposition difficult. Therefore, you can trim this off using Metzenbaum scissors along the very edge of your incision. Select a suitable suture material, for which I would tend to use 3-0 PDS. Place your first knot at one end of the incision and make sure you do a suitable number of throws. So for PDS, I would tend to use between 5 and 6 throws in addition to your initial square knot. Alternatively, Maxon can be used for this as well. You then proceed to close your enterotomy. I would tend to use a simple continuous suture pattern, but you can use a simple interrupted pattern, with the key thing being that you're placing appositional full thickness sutures. And full thickness sutures ensure that the submucosa is engaged, as this is the strength holding layer of the small intestine. Your bites should be between 3 to 5 millimeters apart, and the more even they are, the more accurate apposition you will achieve. Once you have closed your enterotomy, you may notice that you have inadvertently left a larger gap between two sutures. At this stage, you can add additional simple interrupted sutures, as you can see has been done here. Once you're happy with your closure, you can then perform a leak test. This step isn't strictly necessary in every case, but I think when you're starting out with this surgery, it's reassuring to know that your incision line isn't leaking. I tend to perform this using an orange needle, a 20ml syringe with either saline or air. You inject this into the occluded segment of bowel, and I tend to inject until I see saline starting to leak from the suture holes. If it starts to leak from your incision line prior to leaking around the suture, then you probably need to place some additional sutures, which can be simple interrupted. But if it's just leaking from the suture holes, then that's probably a satisfactory repair. The section of bowel can then be emmentalized, and I would just drape this over the section. There's no need to suture it to the affected section of bowel. If you're particularly worried about healing, you could consider doing a serosal patch. Final step in this surgery is to close the abdomen. Before doing this, I'd perform a swab count and an instrument count. The key layer to include when closing the abdomen is the external rectal sheath. We recommend using PDS due to its long strength retention. However, the knot security of PDS is less than other suture materials, and so I do a minimum of 6 throws, and I would also be careful not to cut my suture end too short, as this can encourage your knot to unravel. For suture size, for dogs less than 15 kilos, I would use 2-0 PDS. Between 15 and 13 kilos, I'd use 0 PDS. And in dogs greater than 30 kilos, I would use 1 PDS. There are several postoperative complications you can encounter when performing an enterotomy. Wound complications can include seromas, dehiscence, and infection. Ileus is a common complication that we see after gastrointestinal surgery. There are several things that you can do to minimise the development of ileus postoperatively. Early feeding is beneficial. Adequate analgesia. Prokinetics can be used if ileus is identified. And then also the correction of any electrolyte imbalances, which Chris spoke about earlier in this webinar. The most serious post-operative complication that we can see is intestinal dehiscence and subsequent septic peritonitis. Intestinal healing follows the steps that are common to all wound healing of the inflammatory phase, a proliferation phase, and a maturation phase. During the inflammatory phase of wound healing, the tissue strength is decreasing, as can be seen in this graph. You have a period of time where the strength of the original collagen is getting weaker, and the strength of the new collagen has not begun to increase. The period when the intestinal wall is at its weakest is about 3 to 5 days post-operatively. So if dehiscence is going to occur, this tends to be when? At this stage, dogs or cats are often at home, and so counselling your owners on the signs to monitor for is key. The incidence in cats for an enterotomy is between 1.2 and 3.5%, and in dogs between 1 and 2.5%. Good surgical technique, adhering to Halstead's principles, are the key ways that you can minimise this. That's the end of this presentation looking at how to perform an enterotomy, and the final part of this webinar looking at managing a dog with a small intestinal obstruction. Thank you.